Good morning, good afternoon, good evening, wherever you may be, and welcome back, everyone, to our next session of eSpace Cardiorenal Metabolic 2025 event. It is my pleasure to be joined by my co-chair, Benis Ahmed from Morocco, and Manisha Saeed from India, and by our presenters today. We have Cristina Gavina from University of Porto in Portugal, presenting the cardiologist perspective. David Wheeler from University College London in the UK, presenting the nephrologist perspective. And Antonio Cerello from IRCCS Multimedica in Italy, presenting the diabetologist perspective. After all the presentations, we will conclude with the panel discussion. So please be sure and ask your questions. Pass over to Cristina Gavina for our first presentation.
Hello, it is a pleasure to be here. My name is Cristina Gavina. I'm a clinical cardiologist in Porto, Portugal, and I'm going to talk to you about managing heart and kidney disease in patients with type 2 diabetes and give you a little bit of the cardiology perspective. So these are my disclosures. First of all, I would like to remind you of the overlap there is between type 2 diabetes, heart failure, or established cardiovascular diseases and CKD. This is actually a big problem for patients with type 2 diabetes because you have a lot of mortality and hospitalization due to cardiovascular diseases. And even though they are decreasing along the years, we're not able to close this gap. And concerning CKD, we know that every parameter of CKD disease, either it is eGFR or albuminuria, is clearly worse in patients with type 2 diabetes comparing with the rest of the population. And there is clearly an overlap between all these diseases. And here you can see that approximately 1 in 3 people with type 2 diabetes are going to have cardiovascular diseases, and 20 to 40% of patients with heart failure do have type 2 diabetes. And it also happens that up to 40% of those with type 2 diabetes are going to have also CKD. So concerning the overlap of these diseases and comorbidities, it is important also to see that the impact, the burden that it's going to have is going to be clearly worse when you have more than one comorbidity. And as you're going up in the term of comorbidities, you're going to have worse prognosis. So it is clear that there has to be a shared pathophysiology. And indeed, if we look at it, it probably has to do much with obesity and visceral fat, which is the adipocytes are actually inflamed, are producing a lot of cytokines, and there is a lot of cardiac remodeling, but also kidney remodeling relating to inflammation and fibrosis, and they share the same comorbidities and risk factors. So there are a lot of mechanisms that could actually explain this interplay between these diseases. And the way I see it is that you're going to have one big disease, which is going to be the metabolic component that has to do with adipocytes, and then you're going to have target organ diseases that can be either the kidney or the heart, but also the liver, which is coming into play also in this equation. So the problem is that coining this idea of cardiovascular, kidney, and metabolic syndrome that the American Heart Association has started, you can start from this continuum from no risk factors to having excess adipose tissue that is going to be dysfunctional. Afterwards, you're going to have the metabolic risk factors and CKD, and then you're going to have subclinical diseases, and at the end, the all diversity of manifestations that actually can come in terms of clinical disease. So we should probably be targeting all these different mechanisms if we do want to be effective in slowing the progression to this end organ disease. So we have 4 different drug classes which work through different mechanisms, but that they are kind of additive. And these are the mechanisms that SGLT2 inhibitors, GLP-1 receptor agonists, MRAs, especially non-steroidal MRAs and RAS inhibition can have in terms of cardio and renal protection. And we do have a lot of evidence in terms of trials that have shown that this is possible, and it is possible to reduce specifically heart failure admissions and cardiovascular death in case of patients with heart disease, and it is possible also to protect the kidney. So all these pillars should come together, and you should probably tackling all these pillars if you do want to have good outcomes in people that have this overlap of diseases. So probably the way to go is going to be combination therapy. And there are some interesting data about how combination therapy can actually be important. And in this study, where they tried to understand what would be the potential benefit of combining therapy using a lot of data from the GLP-1 receptor agonists, SGLT2 inhibitors, and finerenone studies, you can see that every time you add a new class, you're going to have a clear benefit in terms of cardiovascular and renal outcomes. And this means at the end that for me, it is important to know that this could increase 3.2 survival free from MACE for my patients, 3.2 survival free of heart failure hospitalizations, 5.5 of patients without progression of chronic kidney disease. So at the end, the main messages to me would be that you're going to have SGLT2 inhibitors, GLP-1 receptor agonists, finerenone, and RASI as mandatory drugs for patients with type 2 diabetics for cardiovascular protection. And also keep in mind that you have to protect the kidney if you want to protect the heart. Thank you for your attention.
So hello everybody, my inertia in cardiorenal metabolic or cardio-kidney metabolic disease. My disclosures are at the bottom of the slide. So this is the sort of patient that I look after. He's a 73-year-old male with type 2 diabetes. He's got end-stage kidney disease. He's needing hemodialysis 3 times a week. He's registered blind because of his diabetic retinopathy. He's had a heart attack, leaving him with a reduced ejection fraction, and he's had a left midfoot amputation because of peripheral vascular disease. So a miserable existence for this poor man on dialysis. And I would argue that this is what happens if clinical inertia sets in, and that we have the potential to prevent this sort of disaster by intervening early and picking up the problems at an earlier stage. I just need to quickly describe the KDIGO heat map for the classification of chronic kidney disease. This classifies chronic kidney disease according to the estimated GFR in the rows and the amount of albumin corrected for creatinine in the urine, the urinary albumin to creatinine ratio. And you'll see here in the heat map different colors representing increased risk at lower levels of eGFR and higher levels of albuminuria. So this is now the standard classification system for chronic kidney disease around the world, and we're going to use this in the talk. So the man I've just shown you is on dialysis. He has an eGFR below 15, and it is too late in this man to intervene to slow progression of his kidney disease. So we want to pick up patients with kidney disease earlier and intervene earlier. So let's just go back to the classic description of diabetic kidney disease. On the left-hand y-axis, we have the eGFR. On the right-hand y-axis, we have the urinary albumin to creatinine ratio. So blue line GFR, red line UACR respectively. And on the x-axis, we have time in years since the diagnosis of diabetes. So the man I've just shown you is way on the right here. He's got a GFR of less than 15. He has end-stage kidney disease and he's on dialysis. So we want to pick up patients earlier. What if we picked up patients when the eGFR dropped below 60? So eGFR less than 60, whatever the level of albumin in the urine, if we could pick patients up at this point, we could probably do a lot more to help them. But let me just highlight the fact that when eGFR drops below 60, if you look at the chart at the bottom here, the patient has already lost around about 80% of nephron mass. So this is actually a late stage in kidney disease. The kidney has a propensity to compensate, and when eGFR drops below 60, we've lost a lot of nephron mass, but we can still do something. And we know we can do something because of clinical trials of therapeutic interventions that we know slow progression of kidney disease in these patients. So here is the KDIGO heat map again. Here we've got patients with eGFRs between 60 and 30. You can see the risk is increased with the higher levels of albumin in the urine, and these patients are potentially heading for a crisis. And we know from clinical trials that in this patient group, ACEs or ARBs, SGLT2 inhibitors, the third generation mineralocorticoid receptor finerenone, and the glucagon peptide receptor agonist semaglutide all slow progression of kidney disease and improve outcomes in these patients. So in this group I've just described, we have 4 agents that we can add in our efforts to protect kidney function. And that's why we do not need clinical inertia. We need to pick up these patients and actively treat them to protect their residual kidney function. What might we achieve? Well, this is a mathematical construct from data derived from the DAPA-CKD trial. So DAPA-CKD was a trial of dapagliflozin compared to placebo in patients with chronic kidney disease, both with and without type 2 diabetes, and demonstrated the benefits of dapagliflozin in CKD. This is a mathematical construct from the trial showing a hypothetical patient with an eGFR of 30 who started on dapagliflozin in the green line, or who's left on a placebo or standard of care, background care in the orange line. And you'll see that by putting this patient on dapagliflozin, theoretically, based on the data from the trial, we could delay the point that patient reached an eGFR of 10 and therefore likely required dialysis by around about 6 years. And what we've done here is we've changed the slope of eGFR decline over time. We've changed the rate of loss of kidney function. But we could do better if we started at 60. So here's hypothetical patient, eGFR of 60. This shows the change of slope of eGFR that we could achieve by treating that patient with dapagliflozin compared to standard of care or placebo as it was in the trial. And you'll see here, we can change the rate of loss of kidney function over time. And by doing that, we can delay that point the patient reaches that eGFR of 10 and therefore likely requires dialysis by around about 11 years. So the earlier we intervene, the bigger the benefit we're likely to have on delaying kidney function. But let's go even earlier. Let's go back to the point in the diabetic patient where we first see the development of albuminuria. So here we go. And at this point, we've still got 80% of nephron mass remaining. We've only lost about 20% of nephron mass. This is a much earlier stage of chronic kidney disease. And if we're going to prevent the patient getting to dialysis, this may be a really good time to pick up the kidney disease based on the urinary albumin to creatinine ratio. Note that the eGFR may be normal or above normal at this stage because the patient is hyperfiltering. So these are the patients we're talking about. They have eGFRs of greater than 60. They have elevated levels of UACR, and you can see them in the chart here. Best opportunity to intervene. Find these patients, get them onto the evidence-based therapies. And we know from clinical trials that this is effective, and these are the well-known trials of the SGLT2 inhibitors mandated by the regulators to demonstrate the cardiovascular safety of these drugs. So in the EMPA-REG outcome, the CANVAS program, and the DECLARE TIMI 58 trials of empagliflozin, canagliflozin, and dapagliflozin, respectively, we saw kidney benefits. And you're seeing here the cumulative probability of kidney events reduced during the time frame of the trial in patients randomized to the active gliflozin compared to the placebo. And if we look at patients in those trials who had the very earliest stages of chronic kidney disease with microalbuminuria or macroalbuminuria, as we used to call it, that stage G2 and G3, stage A2 and A3 levels of albuminuria in the KDIGO classification, we see that in patients randomized to the active drug, and this is from the DECLARE trial of dapagliflozin, fewer patients progressed from no albuminuria to micro or macroalbuminuria. few patients progressed from normal or micro to macroalbuminuria, and so on, and more patients regressed from micro to macro to normal or microalbuminuria on the active drug compared to placebo. So here are those very early patients in a trial, and you're seeing here the benefits in terms of reversing or slowing the development of their diabetic kidney disease. Again, another construct, this time from the 𝐴MPA kidney study, showing a patient, a hypothetical patient from the trial, started on empagliflozin at an eGFR of 85 compared to a placebo or standard of care. You can see here a massive 26.6-year delay in that patient reaching an eGFR of 10 mils per minute and therefore requiring dialysis. So really big impact on delaying kidney failure. And of course, if this is an elderly patient, it's very likely that the patient will not need dialysis treatment during their lifetime. Notice that we still have an impact if we start a patient at 20 on the left-hand side, but that's a much bigger difference comparing the active group with the placebo. So let me summarize. We diagnose chronic kidney disease based on the urinary albumin to creatinine ratio and the eGFR. We have a two-dimensional classification system. We want to pick up patients when they first develop albuminuria, particularly when they have type 2 diabetes. Early intervention in this group is likely to have the biggest impact on slowing progression of kidney disease and may delay or avoid that patient needing dialysis during their lifetime. I've said a little bit about the treatments we may offer these patients, but after lifestyle modifications, we want to intervene with ACEs or ARBs and SGLT2s. And we now know from more recent trials that the third generation mineralocorticoid receptor antagonists and the GLP-1RA's semaglutide also have an impact on slowing progression of kidney disease and improving cardiovascular outcomes in these patients. So there's no room for clinical inertia in chronic kidney disease. Let's diagnose chronic kidney disease early, and let's start these evidence-based therapies as early as we can to improve the outcomes for these patients. Thank you very much for listening to me.
Hello, everybody, and welcome to this webinar, which is focalized on how we can manage heart and kidney disease in patients with type 2. And my role is to share a diabetologist's perspective. Of course, I am a diabetologist. My name is Antonio Ceriello. I am a research consultant at the IRCCS Multimedica in Milan and professor of adjunct professor of internal medicine at the Vanvitelli University of Naples. So this topic is, of course, very cool and hot today, and I will try to give you a different perspective on probably what would be presented by my colleagues, particularly by cardiologists. These are my conflict of interest. We have this algorithm developed yearly by the American Diabetes Association, very often in cooperation with the European Association for the Study of Diabetes. And you may see that it's quite advanced because it is recommended that when people with diabetes is at high risk of already presenting cardiovascular complications, particularly heart failure or kidney disease, the best solution for the treatment is an SGLT1 receptor agonist or an SGLT2 inhibitor. Particularly in presence of heart failure, we should prefer an SGLT2 inhibitor. In presence of cardiovascular disease, a GLP-1 receptor agonist, and when kidney disease is also present, SGLT2 also should be preferred. On the other hand, on the other side, we have recommendations how to manage hyperglycemia, and particularly when hyperglycemia is in presence of obesity, when these kind of conditions are not present. And again, there is a role for these two classes of drugs, but of course also for other well-known classes of class for the treatment of hyperglycemia in diabetes. These are the current clinical practice recommendations, which will be launched in Bangkok at the World Congress of Diabetes on the 8th of April, but they have been already pre-launched, so I can share with you. And what is interesting in these guidelines is that they are settled according to different levels, the best solution and the minimum solutions. Why? We speak about, I was a chairman of this initiative, because optimal care is what could be the best solution for the treatment of diabetes, particularly of hyperglycemia in diabetes. But basic care means no less than this as a right for the treatment for people with diabetes. And if you see, there is something quite new, particularly for optimal care, that until now has been not so strongly recommended in other guidelines. It is that you can consider combination therapy as a starting therapy directly. Of course, when the risk for cardiorenal complications, again, we suggest to use an SGLT2 inhibitor in presence of heart failure of renal disease, or metformin and GLP-1 receptor in presence of cardiovascular disease for optimal care, and SGLT2 plus metformin in the basic care, considering that the SGLT2 inhibitors today are not very expensive in a large part of the world, because please remember that what ADA and ESD are recommending are usually based on Europe and the United States, where the possibility to access to these new therapies is quite high, if not for everybody yet. So, but the world is very huge, and you have many, many people who are not who are living in these countries. So, and again, while the previous recommendations are for people who are just starting the therapy, being at the diagnosis, when the people are already diagnosed and already on therapy, we see here that the situation is that can add for optimal care and SGLT2 or GLP-1 agonist as a further choice, and again, add an SGLT2 as a further choice in the optimal care or basic care, respectively. But I want to share with you something that is very, very linked to diabetes, which probably is not well known by in other fields, which is the concept of the metabolic memory, also legacy, so-called legacy effect of hyperglycemia, which means that what you do at the beginning of diagnosis in terms of early intensive treatment of hyperglycemia is very beneficial in preventing the complications, particularly cardiovascular complications, even after many, many years. This concept has been very recently stressed by this article looking at the long-term follow-up of the UK-PDS, which is a well-known trial in diabetes that was showing in 1998 that intensive glucose control can prevent diabetic complications, and also confirming the existence of so-called metabolic memory. But in this long-term follow-up, meaning 24 years follow-up, you see here that this concept has been confirmed, meaning that what we do at the beginning in terms of optimal glycemic control can last even after 24 years. So what we do at the beginning is very important. According to this issue, because in the UK PDS, the only drug which were used were sulfonylureas, metformin, and insulin, being the trial started in the 90s, we had these research questions. What about the use in SGLT2, which are now available? Using a huge Italian database, including more than 1 million people, we settled a group of people who were at diagnosis free of any complications. And we look at what happens if you introduce an SGLT2 in the therapy after 1 year, 2 years, or 3 years from the diagnosis. We found out, first of all, we were able to confirm that the legacy effect exists in our group, you can see here. But for the first time, we were able to show that if an SGLT2 inhibitor is introduced in the therapy, after 1 or 2 years, this can prevent the appearance of the metabolic memory. Meaning that if you introduce an SGLT2 as within 2 years from the diagnosis, you have the chance to avoid the metabolic memory appearance. And the conclusion of the practical conclusion of this work that we should introduce as soon as possible an SGLT2 in the therapy of type 2 diabetes to prevent complications, including and particularly cardiorenal complications. And this has been further confirmed, this approach, by a Chinese study using the same approach we have used, but because they had the possibility to also to have a huge number of people treated with the GLP-1 receptor agonist, this group was able to show the same effect for SGLT2 inhibitors and GLP-1 receptor agonists. So it's good news, because this means that if you can introduce these two classes of drugs within 2 years from the diagnosis, you have the chance to really improve long-term prognosis for any kind of complications, particularly, again, I want to stress cardiorenal complications. And also, I want to stress the concept of the target. You know, the target of hyperglycemia has been settled always at 7% of A1C. But we have shown, published in Diabetes very recently, that if you look at the population of people with diabetes having being free of complications at the entering the study, and during the follow-up having an A1C between 5.7 and less than 7, this does not exclude the risk for complications, particularly cardiorenal complications, which means that the new target should be settled for the management of diabetes, meaning that the ideal target now should be considered 5.7%. And finally, this huge real-world evidence suggests that if you introduce an SGLT2 or GLP-1 receptor agonist in the real life therapy, this is more effective than any kind of other treatment in preventing complications, of course, particularly cardiorenal complications. So in conclusion, the diabetologist's point of view is that this new class of drugs must be used not only for simple prevention of cardiovascular and renal complications, but also for optimal control of glycemia and to abolish the appearance of the metabolic memory, which can last for many, many years. Thank you for your attention.
Thank you for all speakers. It was very interesting and amazing presentation. And my first question is to Professor Wheeler. We have now 4 pillars for protect kidney in diabetes. What's your first choice? Do you choose SGLT2 or GLP-1 agonist or fall together at earlier to more protect kidney?
That's a great question. I think we should remember that most of the trials, the newer trials, have been done on a background of ACE or ARB therapy. So I think that's our starting point. ACE or ARB, if the patient tolerates, we then add in SGLT2s, I think, as the next logical therapy. We have some data to suggest that starting the SGLT2 allows persistence of the ACE and ARB because of a reduction in potassium. So that's helpful. We then, I think, as a third line, add in a third generation mineralocorticoid receptor antagonist, assuming the potassium is under control. And then the GLP-1 is often used anyway for the diabetic control in that patient. And so the patient may well be on a GLP-1RA anyway. But I think that's our usual sequence. Of course, as we've heard, we do need evidence that adding one therapy on top of another has additional benefit. But at present, we are very keen to get these patients on as many of these therapies as possible.
And second question, how do you look at the earlier the dropped eGFR when you introduce SGLT2? How do you look at that? Is how prognosis of that and how nephrologists look this earlier drop of eGFR?
So this is a difficult one. We are trying to improve kidney function, but when we start a patient on an ACE or an ARB or an SGLT2 and possibly on an MRA as well, then we see a reduction in eGFR, meaning that the kidney function initially is worse than before we started the therapy. We know that that is actually a sign that we have reduced the pressure within the glomerulus, and that in the long term is a good thing for the kidney because the glomerulus is working at a lower pressure and will last for longer. We are not recommending checks of eGFR 2 weeks after starting SGLT2s. There is no increased risk of acute kidney injury, in fact, quite the opposite. And so we're pretty chilled about those eGFR drops. They are telling us that the drug is working and that something's good is happening.
Okay. And how do you look GLP-1 agonist in nephroprotection? We had the FLOW trial. We have ongoing trial with tirzepatide. And how do you look this molecule? Is that new statin for kidney with SGLT2?
Well, I think we need a little bit more data. I mean, the data from FLOW on slowing progression of kidney disease, reducing cardiovascular risk, reducing mortality was phenomenal. We were so excited to see that as a nephrology community. And of course, you know, we were already recommending these drugs as drugs that could be used to control diabetes in patients with advanced kidney disease because they don't accumulate like sulfonylureas. And now we've got this outcome data that this is even better. And of course, we're looking forward to those other trials. And the big question is, do these drugs work in non-diabetic kidney disease, which, of course, we know the SGLT2s do.
Other question, do you start SGLT2 in late renal stage when eGFR is at 20, 25?
Well, the trials to date have recruited patients down to an eGFR of 20 mils per minute. That was the EMPA kidney trial recruited patients down to an eGFR of 20 mil per minute. There are some data now coming out in patients who have lower eGFRs. And of course, in the trials we conducted, there were patients whose eGFRs drifted below 20 during the study. And we haven't picked up any adverse safety signals in those patients. We have patients starting dialysis on these drugs with no obvious safety risk. We don't know about the benefits, but I think we're not worried about patients on these drugs drifting to low eGFRs below 20. Whether we should be starting patients below an eGFR of 20, I think is a more difficult question, and we need more evidence to support that strategy. And there are trials ongoing in patients who have eGFRs below 20 at the start of therapy.
Gloria, have you any question or?
Yes, I just want to thank David for that talk, especially his last words saying there's no room for clinical inertia in CKD. I really agree with you on that. So I just wanted to ask, has there been any trial of using the two drugs, that is ACE inhibitors and SGLT1 inhibitors.
So, I mean, the Credence trial, the DAPA-CKD trial, and the EMPA-KIDNEY trial all used an SGLT2 inhibitor on the top of background ACE or ARB therapy. Now, not all of the patients were on ACEs or ARBs. Some of them weren't. And we've, from the analysis we've done and looked at, it does seem that the SGLT2s have a benefit, even if the patient isn't on an ACE or ARB, which is what we would expect. So I think, yeah, it's pretty standard now to add the SGLT2 to background ACE or ARB. And we like to encourage individuals to maximize the background ACE and ARB before starting the SGLT2. But I think your point about...
Because when... Sorry, just go ahead.
Back to your point about the early intervention. The message is not for nephrologists because we see patients late. The message is to the whole medical community looking after cardiorenal metabolic patients. The diabetologists, the cardiologists are going to see these patients with the earliest changes, the earliest signs of kidney disease. And the nephrologists are not going to see these patients because they're only looking after them at the advanced stages. So it's a message for the whole medical community really that we want to get out there. Thank you.
Professor Wheeler, the barrier?
Oh, sorry.
Professor Wheeler, what is the barrier to use R4 pillar? What's the problem wrong with the in medical community? There's many problems of medical inertia. And there's some resistance in some diabetologists to SGLT2 to GLP-1 agonist. There are some old school to prefer insulin, to prefer sulfamide, and when we see the prescription, we didn't find SGLT2, GLP-1 agonist. What's wrong? How we can overcome all this barrier?
Yeah, it's a great question. And I'm not a diabetologist and I should not be telling diabetologists how to manage diabetes. That's not my role. What I do know is that in a patient with diabetes and kidney disease, that these drugs are effective at slowing progression of kidney disease and reducing cardiovascular risk. And what we also know from those cardiovascular safety trials that we mentioned, and we're celebrating, 10 years since the EMPA-REG result came out now. We do know from those trials that patients on the SGLT2 who didn't have kidney disease at the start of the trial were less likely to develop the earliest stages of kidney disease during the study. So for a nephrologist, it's a no-brainer to get patients with diabetes on these evidence-based medicines that prevent, heart and kidney damage and improve outcomes for these patients. But there are barriers. There's the expense, I guess, of some of these therapies. GLP-1s are injectables, although we're seeing, I think, generics coming through now in certain countries of the world. But and we're also getting, of course, oral GLP-1s, which may well get around some of these problems. But then, I think the main problem for nephrologists is hyperkalemia. And if you're going to take a patient with stage 4 CKD and EGFR below 30, and you're going to start you're going to maximize an ACE and an ARB, add in an MRA, finerenone, you're likely to see problems with potassium. But why don't we use if you've got a choice as a patient, I put myself in the patient position. I'm a diabetic patient. I'm going to be treated for diabetes. I'm offered a drug that might lower my blood sugar, but has no proven effects on my organs and my long-term outcomes, or a drug that will control my blood sugar and prevent me getting heart failure and kidney failure. I think I'd choose the drug that prevented me getting the heart failure and the kidney failure. It's a no-brainer, I think, for a patient if you put it that way to the patient. So I think we need to wake up and think about, long-term organ protection in these patients.
Can I ask a question at this point, Dr. Wheeler? So thank you for the nice presentation. Excellent talks, all of them. So my question is, in 𝐴𝐴𝐴 trial, we did have patients without proteinuria, and the inclusion criteria said that you could include patients without proteinuria provided the GFR was less than 45. DAPA-CKD did not have any patients without proteinuria. My question to you is, now we know that SGLT2 drugs are so good and they delay the dialysis by so many years. So what would you do if you have a patient with GFR 60 or even more, no proteinuria and diabetes? Will you still start SGLT2 for them? So that's question number one. And would you start SGLT2 for all diabetics even before you put them on metformin? That's question number two.
So question number one, I think I can deal with. I mean, I think it depends on, level of risk. So the 𝐴𝐴𝐴 kidney data do show that in patients with an eGFR between 20 and 45 who do not have albuminuria, then there was a slowing of the slope or a less rapid loss of eGFR over time in that patient group. So that was a good signal and means that these drugs are probably helping patients in that group. But we do need to remember that these are lower risk patients by the very virtue of the absence of albuminuria. They are lower at risk of kidney failure. They are at lower risk of cardiovascular disease, bad outcomes, and so on. So I think, in the non-diabetic patient, you have to look at the risk to benefit of the drug. But if you want to offer that patient the best treatment, and you want to preserve as much kidney function for as long as possible, then an SGLT2 is logical in a patient with an eGFR between 20 and 45 who has no albuminuria. The other patient you mentioned, that's more, I think, a question for a diabetologist that I probably shouldn't answer. But, if you've got a patient with an eGFR of 60, no albumin in the urine, would you start an SGLT2 inhibitor over and above metformin to treat diabetes? I think, as I say, I think that's a question for diabetologists. We are still, we are very happy with diabetic patients coming to us on metformin as long as their eGFRs are greater than 60. And we recognize that these patients may need multiple drugs to control their blood sugar. So metformin seems a logical choice. And then, when you need the second drug and you've got the choice perhaps between a DPP4, sulfonylurea, and an SGLT2, the logic to me is the SGLT2, although we really don't have good evidence. In fact, we have very little evidence at all in that group of patients you've described with eGFRs of around 60 and no albuminuria. So it's difficult to justify an SGLT2 from a kidney perspective without that evidence.
One of most challenge for cardiologists is the heart failure with CKD, particularly in heart failure with reduction ejection fraction. Now we have also preserved ejection fraction is a great problem. How do you see this problem and difficulties for together between cardiologists and nephrologists in this kind of patients, heart failure with CKD, and what is the difficulty? How will you collaborate with the cardiologists?
Yeah. So a great question. I think we're all trying to do the same thing here for the patient. We of course have patients with advanced chronic kidney disease who have heart failure, most with preserved ejection fraction, some with reduced ejection fraction. How do we manage these patients jointly? What we do is we have a multidisciplinary meeting where we pull in virtually on a virtual platform the cardiology expertise, the diabetology expertise, and the kidney expertise. This is often nurse-led, but we do get consultants joining this meeting, and we come to a consensus as to what the best drug combination would be for the particular patient, both in terms of managing their diabetes, in terms of managing their heart failure, and in terms of managing their kidney failure. And you can imagine that we are usually recommending an SGLT2 inhibitor in these patients from the kidney, diabetes, and cardiovascular perspective. But yeah, and we are getting many of these patients on SGLT2 inhibitors anyway, and hoping that this is good for their heart failure with either preserved or reduced ejection fraction.
Gloria, have you other question?
Yes. Sorry, I was just wondering, for us in Africa, these drugs are not yet, I mean, the SGL2 inhibitors, they are not very much available. And the other problem would be cost.
Yeah.
So
yeah.
What do you think, or how do you think this can be made more accessible to everyone?
It's a great question, Gloria. So I attended a launch in South Africa of dapagliflozin, and in fact, the sponsor, the manufacturer of dapagliflozin, had also introduced a generic dapagliflozin that was cheaper.
Yeah, that
was becoming available. I was at the World Congress of Nephrology in India in February, and I Googled SGLT2 inhibitors, and I was able to get a month's worth of an SGLT2 inhibitor for $8. So I think the introduction of these generics is going to help an awful lot with the cost. So India, a month's worth of an SGLT2 inhibitor, $8. I know it's still a lot of money, but it's, you know, from a cost effectiveness perspective, that really is a competitive price. And I'm hoping that these generics will spread throughout Africa so that you can get your hands on these drugs at prices that are reasonable within your healthcare systems. The GLP-1s are also coming in now as generics in some countries, so we might not have to wait too long until you have affordable access to affordable GLP-1s in parts of Africa, hopefully all of Africa eventually.
We have a lot of discussion. Okay, sorry.
No, nothing, just telling about the generics. So now even empagliflozin has come off patent. So that's good news last week. So we have now many generics for empagliflozin as well. And DAPA is, I mean, you have it available in all the government hospital settings as well. So almost 70 to 80% of patients needing DAPA are on the drug in India. So that's very happy news.
How do you think we have a lot of, we have a lot of discussion of the GLP-1 agonist and SGLT2. What do you think about finerenone in nephroprotection? What do you think about after Figaro, Fidelio? What is the exact place of finerenone?
So just going back to those two trials of finerenone, they were conducted in patients with diabetic kidney disease. Fidelio looked more at kidney outcomes, Figaro looked more at the cardiovascular outcomes, but the messages from both trials were really very clear that on top of ACE or ARB therapy, finerenone led to an added improvement in terms of slowing the progression of the kidney disease, preventing the bad kidney outcomes, and also in reducing the cardiovascular risk. Now, in those trials, you know, around about 4 or 5% of patients were on SGLT2s as well as ACEs and ARBs. So I think the bigger question is the value of finerenone on top of SGLT2s. I think we have some data from those trials to suggest there was an additive benefit of adding finerenone to ACE or ARB plus SGLT2. Adding the finerenone in was still a benefit to the patients. And we have similar analyses of the SGLT2 inhibitor trials. If we go back to DAPA-CKD, we had around about 4% of patients on an MRA. It was mainly spironolactone. But looking at those patients, although it's a small group, they seem to gain the same benefits, or the benefit was consistent in those patients compared to the patients who weren't on the MRA. So I think we're looking at, you know, additive therapies, as I say, if the potassium allows us to add the MRA to the ACE and ARB in those patients. And that, of course, is all in diabetic kidney disease. We don't have trials of third generation MRAs in non-diabetic kidney disease just yet. We have kidney data from the cardiovascular trial, Fine Arts, but we haven't seen, you know, a kidney trial yet of MRAs or third generation MRAs in non-diabetic kidney disease.
In fine arts, there was not protection by phenylalanine. How do we explain that?
Yeah, it's difficult. It's probably not the first study of heart failure with preserved ejection fraction in which, drugs that protect kidney function in other scenarios have not been shown to be beneficial. I think these may be patients at lower risk of kidney endpoints. They may have less albuminuria, that they're at lower risk. And I don't think this should discourage us from using these drugs in these patient groups. But, not all trials give the results that we expect. And that was perhaps a little bit of a surprise. I think we will have trials coming through in patients at higher risk of progressive kidney disease. And I think we should reserve judgment until we see the outcomes of using a third generation MRA in higher risk CKD patients.
One of difficult for us is hyperkalemia, potassium in end-stage renal stage, particularly when you use HSH2 or use IRB, or it's how do you manage this problem of hyperkalemia as nephrologist?
So this is our worst enemy in a way. I look after patients with EGFRs of less than 20. I'm trying to prevent them getting kidney failure, and I'm wanting to maximize ACEs and ARBs and mineralocorticoid receptor antagonists if they've got diabetic kidney disease. And potassium limits our ability to do that. So our tricks are low potassium diets, giving oral sodium bicarbonate, which neutralizes their metabolic acidosis. The kidney has the choice of excreting protons to get rid of acid or potassium and cannot do both at the same time. So if you neutralize the acidosis, the kidney can concentrate on getting rid of the potassium rather than having to get rid of the acid. So that helps. We put patients on loop diuretics that help leak potassium into the urine, and we offer patients long-term potassium binders, the newer potassium binders that we can use in the longer term as agents that help us or help enable the long-term RAS blockade. So sodium zirconium cyclosilicate, for example, as a long-term potassium binder. That's the 𝐾𝐞.
Gloria, have you other questions?
David, yes, I want to find out from David, what are the side effects, what major side effects have you faced with using these drugs? The SGLT.
SGLT2s in chronic kidney disease,
especially,
remarkably few side effects. We were, as nephrologists, we were really worried about urinary tract infection, urinary tract bacteremia, urosepsis from bacterial infection. And it really doesn't happen. We don't see it. We didn't really see it in the trials. But you'd think that enhancing glucose excretion in the urine would enhance bacterial urinary tract infection. It doesn't happen. Of course, we see genital fungal infection, and that can be a problem in some patients, particularly if the genital hygiene is not up to standard, and we help patients with that. We occasionally see elderly patients who get a little bit dehydrated and drop their blood pressure when we add these drugs. These drugs, of course, have sodium, have natriuretic properties. They enhance sodium excretion. They're diuretics. So we sometimes see a little bit of volume depletion. And with some of these agents, we've seen an increased risk of ketoacidosis, which is why we would not give these drugs as nephrologists to patients with a history of ketoacidosis. Neither would we give these drugs to patients with type 1 diabetes without approval from colleagues in the diabetology department.
So just
Professor
to follow
Wheeler.
up on that, do you normally counsel, especially the women, of this risk on, ways to take care of this? Yeah.
There's an obligation to do that. That is a recommendation in the UK. And there's also a recommendation to warn patients about the potential for Fournier's gangrene, which is an incredibly rare complication of these drugs, but a complication of diabetes generally. So we do talk about the potential for fungal or bacterial infection in the genital area as part of our counselling. But I think you have to
Professor
balance
Wheeler,
that
Be very important
with
for
the benefits. Yeah, with the benefits of the
Yeah.
drugs.
Professor Wheeler, there is an ongoing trial on dapagliflozin in embryo stage. Do you think that the trial is going to be positive?
In end stage kidney disease.
Yes. Yeah.
There is the lifestyle study ongoing in the Netherlands and other countries where patients have been randomized to dapagliflozin or to placebo. These patients have EGFRs of less than 20. There are patients on dialysis in that trial. There are patients with kidney transplants in that trial. And I think we really need those data to understand the true benefits of these drugs. I never like to predict the results of a trial while the trial is ongoing, so I won't be drawn on that. I think we already know that patients with EGFRs between 15 and 20 show some benefit from randomization to SGLT2 inhibitors. So I'll just say that if there is a population in that trial who might benefit, it may well be those with EGFRs, between 15 and 20. And I think we know that from some other studies that have been published recently from other countries.
Just the last question. I was in ECC and we have two trials about semaglutide, STRIDE trial and SALT trial. How do you see this new trial?
Yeah, I mean, I think they are consistent. They enhance the data we've got already. They demonstrate the broader benefits of these drugs in, heart disease, which I think was a surprise to me that these drugs seem to be, good drugs for heart disease. And I think they will encourage us to use these drugs more widely in patients with kidney disease, particularly patients who need to lose weight. And I think, we are waiting to learn more about the kidney benefits of these drugs in broader populations, not just those that we studied in the FLOW trial. So, yeah, I think it's good to see more trials, and there will be more trials looking at kidney outcomes, as you suggested earlier.
Many thanks, and Gloria for conclusion.
Okay. So I want to really thank you, David, for staying on with us and for bringing more light from the answers to the questions. This brings us to the end of this session, managing heart and kidney in patients with type 2 diabetes. I hope that you found this session informative and to have answered any questions you may have had. Please stay tuned for the next session starting shortly. Thank you very much. Thank you again to Cristina Gavina, to David Wheeler, and Antonio Cerello. Thank you.